Good morning. First of all, I would like to thank Coloproctology 2022 for giving me this opportunity to share a topic on stoma complication, prevention and management of prolapse. I'm sure many of you here have managed stoma before, be it a simple stoma or a stoma with complication. The topic outlined today will be a brief introduction about the common complication, followed by focus on stoma prolapse, the prevalence and also contributing factors to it. With that, we'll go to the preventive measure and the management, nursing management, as well as surgical management. In the course of managing this, there will be a lot of challenges as well, which will be covered in this topic. Yeah. Okay, common complications, some of the common complications, not all, yeah. Example, the early complication as well as the late complication. Early complication is usually within days or within a month post-op. Example like necrosis or mucocutaneous separation can occur quite early in the after surgery. Retraction can also happen after the stoma rod has been removed. And besides that, you also can see other conditions like skin excoriation due to the poor sighting, or sometimes other reasons as well. Besides that, pyodermal gangrenosum is more commonly in patients with diabetes, but it doesn't happen very often generally. For the late complication, you can see here there's hernia and prolapse, which will be covered more in detail today. When we talk about stoma prolapse, it has to be something to do with the length, correct? So if you look at the length, what is the ideal length? Yeah, look at this picture here, moderately protruding, which is about approximately 1 to 3 cm above the skin. When you look at this stoma here, you will be very happy because the stoma is quite easier to manage. Whereas if you have a stoma that is little or no protrusion from the skin level, you will have some headache, yeah, because it is not so easy to manage, especially if the stoma is from the ileostomy. If ileostomy output doesn't flow into the back, it will accumulate around the side, and because it's so corrosive, it will cause the skin excoriation, yeah. And if you look at the stoma here, it is a little bit protruding, but it is also not good enough because it's located at the receded area below. So generally it's below skin level, yeah. And of course, there's another one that is a bit too long. It's greater than 3 cm of the intestine that's protruding out from the skin surface. In fact, this one is easier to manage, but a bit not so nice to look at aesthetically, yeah. Again, the length will depend on the types of stoma. If it's ileostomy, 1 cm is not good enough. Normally it's about 2.5 cm to 3 will be the ideal, yeah, because it's watery and it leaks easier. Now we focus more on the stoma prolapse now. According to Canadian Society of Intestinal Research 2022, a prolapse is a stoma that essentially telescopes out through itself, causing abnormal lengthening. If you look at the stoma picture here, the same patient, earlier maybe the stoma prolapse is not so severe, but as it goes by day, it actually prolapses more and more. And okay, when you look at these two pictures here, it's actually the sagittal view or the side view of the of a complication. This is the top picture and this is considered the bottom picture. Can you let me know, can you tell which one is the side view of a stoma prolapse? Yeah, the top one or the bottom one? Just type in the chat box if you know. Okay, while waiting for everyone to type in, we will go on to the incidence of stoma prolapse. Yeah, it is said that it ranges from 6 to 26% according to clinical colon rectum surgery 2008. But in many other studies, it stays more or less the same. Some may be going up to about 30%. Yeah, and of course, it also says that transverse colostomy is having higher rate of stoma prolapse. The reason of the range is also related to this, because if the stoma is at the colostomy or ileostomy, it varies a bit. Yeah, transverse loop colostomy seems to have a higher rate of prolapse, and it is also more commonly happen at the distal lip of a loop stoma, whether it's a colostomy or ileostomy. Okay, now we can look at the picture now. The first one is actually prolapse. So the picture is below. As I mentioned earlier, that some stoma is with one opening, and some stoma is with loop stoma have got two opening. So the stoma prolapse that is with one lumen will look like this, whereas the stoma that is with two lumen, it will be like this picture here. Yeah, and this is actually the distal loop, which means the output is not coming out from here. It's a non-functioning limb, but because it's non-functioning, it actually tend to be a bit more active in movement, and the prolapse is more often occur in this area, but nobody know why. Yeah. Now this one, it is actually not a prolapse. Yeah, if you can see from here, this is the stoma still in the correct position, never telescope out, whereas there is the other part of the intestine forcing its way out into this sac here to form a hernia. So this is how it looks like. Yeah. Okay, now we look at more studies. Yeah, this is from MBase medical database and the Cochrane library. They searched up to December 2012. It was stated that stoma complications are prevalent. That means it is common. Yeah, it will also contribute to poor quality of life for the ostomy, and it will increase the health economic burdens, because with the complication, they may need more specific ostomy appliance to manage that, or maybe sometimes they need to use much more accessories to manage that as well. And of course, there are also other common reasons why stoma complication occur. One of it says here, most common complications are attributed to stoma construction. Where is the stoma constructed? In OT, of course. Yeah, so it has to be something to do with the skill. And according to the study, it says that attention to the finer technical points performed by experienced surgeons reduces the morbidity. It's the difficulty the patient will face. Young mortality is that, morbidity is the difficulty. And it also says that preoperative stoma site marking or stoma siting and post-operative care by a stoma therapy nurse or ET nurse are crucial for the patient's successful adaptation. So better care will lead to better rehabilitation. It will also improve the quality of life for patients and encourage them to be more independent. It also reduces the rate of complication, yeah, in the long run. Now, let us look at the contributing factors for the stoma prolapse. The first one here, it says that the poor abdominal muscle tone is one of the main factor, especially it happens in infant, because as you know, the infant, their abdominal muscle is not fully developed yet. And the other end of it is actually the more elderly people. As you know, stoma patient, a lot of time they are colorectal cancer, and this group of patients are usually more senior, and their abdominal tone is not so good. It's more laxity at this age already. So this is something that is not reversible lah, yeah. And the other reason is actually weight gain and obesity. You have to be very careful if the patient is having very good appetite after the surgery. Just caution them not to gain weight too much lah, yeah. This is something that is reversible lah, yeah. And of course, pregnancy is one of the most common conditions that the patient may have stoma prolapse if they have a stoma, yeah. And because of the pressure, abdominal pressure is pushing it out. But luckily, this is something that is reversible after the delivery. The prolapse will subside, yeah. And surgical technique is also one important area that will contribute to the stoma prolapse. Example like oversized stoma opening. This can be this can happen is because sometimes the patient, especially emergency operation, the stoma, the intestine was so swollen, edema, and the doctor have no choice but to open a stoma opening that is slightly larger. But it became, it will reduce in size after the stoma have reduced the edema. So after the stoma reduced, it will be too big of a size for the opening and giving chance for the stoma to collapse out. At times it can be also the inadequate fixation of the bowel to the inside. So this more related to the technical part, yeah. And increased pressure within the abdomen can also happen to contribute to stoma prolapse. Very often the patient carry heavy things, or if they have got chronic cough, because all this will add on to the increased pressure. Usually we advise the patient not to carry anything heavier than 5 kg after the operation, at least for the first 3 months. Yeah. Chronic cough, if they have chronic cough, also can contribute to abdominal pressure that can cause the stoma prolapse. And the last one is actually the tumor. At times the patient is at the late stage of colorectal cancer. The tumor is actually getting bigger and pushing it out. This is something very unfortunate sometimes, yeah. Okay, another reason is the stoma prolapse can occur if the colostomy that is brought out through the abdominal incision and it is not placed on the abdominal muscle. As you know, the abdominal muscle is able to help to hold the stoma better. And the stoma sighting is important in this area. Yeah, the stoma sighting usually create the location will be on the lateral side of the abdominal muscle. Now, talking about stoma sighting, some of you may not be aware of it. It is actually a procedure whereby the internist or the surgeon will pre-select a location whereby the doctor will consider it as the best position for the patient to have the stoma. Sometimes all this can, if too far from the abdominal muscle, this is the abdominal muscle. If it's too far from outside, it may also can cause the risk to have stoma prolapse or hernia. Yeah, all these are some of the consideration when we do stoma sighting, which I would not go through. Okay, understanding the contributing factor and also some of the condition. Now we talk about the prevention. Yes, some preventive measure if we can try to help the patient avoid having the complication. First of all, the stoma sighting, of course, is one of the best thing to do, yeah, to be done before the surgery. And the abdominal exercise is good, but need to be guided by a physiotherapist, because if they exercise too vigorously, it may not be good. Yeah, it may cause, it may not help, but it may cause the stoma prolapse. Yeah, and the other preventive measure is to avoid carry heavy items more than 5 kg, which we mentioned before, and avoid the heavy core exercise. Core is abdominal muscle. Yeah, and also advise the patient take care not to gain excessive weight. This is important. Yeah, and after that, if they can, after surgery, they can actually wear a support belt or support garment to support, yeah, to reduce the risk. Yeah, and if they have cough, they have to get early treatment. Okay, if the preventive measure is not successful, then come to the management of the prolapse. Yeah, management can be nursing or surgical management. Yeah, okay. To a patient, when the stoma is prolapsing out, it's very frightening for them. So they will be very anxiously. They call you even midnight, yeah, to tell you their stoma is actually coming out longer and longer, and they want to know whether they will die. Yeah, and normally what we do is to explain to the patient this is a complication, but it's not an emergency. So you have to calm them down, ask them when is their operation, when is their next surgical appointment. If it's within about 1 week, 2 weeks, they can normally wait until the next appointment to see the doctor. But if it's longer than that, I normally will advise them to go to the emergency to get an appointment, or go to the clinic if they can to get an earlier appointment. Okay, after you calm down the patient, ask them to lie down for 15 to 20 minutes. When they relax, the stoma will shrink and slowly it will reduce by itself. But if it cannot go in, then you have to put gentle pressure at the end of the stoma to slowly guide it back. Yeah, what we call the manual reduction. And besides that, if it doesn't go in, sometimes because of the edema too much, too swollen, sometimes we can do cold compress on top of the stoma bag, touching the stoma lah, of course. Yeah, and also can apply sugar or Destro 50 if in the ward, something like this. But for me, I do not like to put the sugar this way because it's quite messy. I will make the sugar paste, thick sugar paste, use a gauze to absorb the sugar paste and apply onto the stoma. Yeah, it will reduce the stoma size, the stoma edema through osmosis. Yeah, because it's heavier outside, the sugar will draw the fluid out. And after that, if the stoma reduce already, then they can apply the bag, and they can also use some support garment. Normally, they need to wait for the stoma to reduce back, then only do the change of appliance. Yeah. And okay, now talking about managing the stoma prolapse, we must know how to teach a patient to apply the ostomy appliances. Yeah, first of all, manual reduction. Yeah, if need to. If not, sometimes when the patient lying down already go in, then okay, they just prepare the thing and they start to do the application. Normally, when they cut the skin barrier, whether it's a one-piece system or two-piece system, they have to accommodate a little bit extra space, because when the stoma prolapse out again, usually it will be slightly bigger. So if they are cutting it according to the size, when the stoma is reduced, when the intestine is pushing out, maybe it will push the wafer or the skin barrier out a little bit as well. And also not to cut too big. If it's too big, when the stoma shrunk in, it will be too much of skin exposed. Yeah, can cause skin excoriation. At the same time, advise them to observe the color of the stoma. If it's bluish, dark red, it may be some poor venous return, so they need to get medical help. Okay, it is also a common occurrence for the patient with prolapse stoma to have skin exploration. Yeah, sometimes maybe the opening is too big when they cut the skin barrier after the stoma have shrunk. Sometimes it's the skin barrier is not properly fitted or the adhesive is not so good, because with the long limb of the stoma that is outside, it is not easy to guide the wafer in. Yeah, at times it could be also complicated with the peristoma skin fold or creases and leakage. Sometimes it's like so complicated they do not want to change it, even there's some leakage underneath already. So when they don't attend to the leakage underneath the stoma, it also can cause the skin to break. Yeah, also be a bit more aware that if the stoma is prolapsed out, cleaning the skin under the stoma is not easy, so need to teach a patient how to clean it correctly, put a gauze underneath to clean it, and have to lay something below so that when the stoma is lying on the skin, it doesn't touch the skin and stain the skin again. Yeah, okay. To manage it, we must know what is the reason for the skin exploration and remove the cause, yeah, the causes that we mentioned above, yeah, and correct the leakage. And for the skin exploration, we need to use stoma powder, and important to use skin barrier for the surrounding skin. At times, may need to use seal or some paste to fill up uneven area. Okay, now managing the stoma prolapse, there are more things to be aware of, yeah. So as a ET nurse, we have to frequently evaluate the prolapse stoma as well as the appliance. Sometimes the appliance over time may be not suitable anymore to use, so we have to advise the patient accordingly. And the patient need to know how to do the manual reduction in order for them to apply the appliances correctly. Yeah, they can use the support belt, of course. And some of the challenges commonly happen. Yeah, the prolapse can extend into the pouch and leave very little space. Patients get very upset because they have to change so often, empty so often. But we always tell the patient it is not advisable to use a bag that is too big as well. If the bag is too long, the stoma prolapse will actually get longer. Yeah, and also the exposed mucosa may also cause some trauma due to the mechanical rubbing against, yeah, either against the bag or against the wafer. Yeah. And it will also interfere with the pouch seal, as I mentioned earlier. The limb of the stoma that is too heavy can be pushing away the stoma adhesive. Yeah, and advise the patient to take care when they clip on the bag. Make sure that there's no pinching between the flange and also the pouch when they cover the bag. Yeah. Otherwise, there will be some bleeding and the patient may not be aware. Okay, now advise the patient when to consult a doctor. Of course, when nursing management is not possible, then need to get the medical help. Yeah, if the prolapse is appear to be purple, blue, or dark red, there's the time, like the picture here, there's a time have to go back to see doctor in the hospital. If the prolapse suddenly become cold, normally it's warm, right? If it's cold, then it is not a good sign. Have to go back to hospital urgent. The prolapse is swollen and not able to reduce back for more than an hour. Yeah, this is also a sign that the patient have to go back to the hospital. Yeah. Sometimes it is unable to reduce even with sugar or with the cold compress. Yeah. Another condition is when the prolapse is painful or bleeding that is the time that you need to advise the patient to go back to hospital. Surgical management, usually there are a few modality. Sometimes if the patient is having emergency, the doctor may decide to do the stoma reversal, even though it's like maybe 1 month before the planned closure date. At times, they may relocate the stoma. Instead of on the right side, they now change it to the left side. But a lot of time, relocation, the stoma prolapse may also recur because of the laxity of the abdominal muscle. Yeah, at times they just do a local resection. Local resection meaning that they just cut off the prolapse limbs. Yeah, and okay, surgical team will consider if the prolapse is too large to manage conservatively, or sometimes there is some blood supply compromise, yeah, like strangulation or obstruction. So then the last slide is actually showing how local resection can be done. Because I have not seen, this is something that I got from the internet. Yeah, they will do the incision on the prolapse bowel, just cut, and then the prolapse colon will be dissected with some ligation of the suture, and after that the prolapse colon will be removed and the inner colon part will be fixed on the abdominal surface. So this will be the new stoma for the patient. With that, I end my session, and this is some of the references, and if any questions we will address after this. Thank you.